Hello everyone, my name is Christina Kiner, and this is my journal review article. The article I picked was called Quervains Tenosynivitis, Going Down the Radius Reduces Pain, an analysis of 36 patients. This article was actually published in the Review of Kinesiotherapy in France in 2019, but I thought that this article was very interesting and I wanted to share it with everybody. The article begins with an introduction to Quervains Tenosynivitis and is expressed by pain due to inflammation of the synovial sheath of the two tendons, the abductor pollicis longus and the extensor pollicis brevis. This inflammation is generated by the friction of these two tendons when they slide in the first dorsal compartment of the extensor retinaculum. The swelling caused by the inflammation leads to an overpressure inside the tunnel, therefore an increase in friction. A vicious cycle then sets in that the swelling increases the friction, which then increases inflammation, and so on. Causes of Quervains Tenosynivitis can include repetitive activities of thumb and wrist, muscle strains, and is commonly associated with pregnancy and breastfeeding mothers. It is most common in middle-aged women. The APL and the EPB induce thumb and wrist abduction on contraction and also ascension of the radius with respect to the ulna in a piston movement, which is an up and down movement. This ascension changes the penetration angle of the two tendons in the first dorsal compartment, increasing friction between the tendons. The author's hypothesis is that if the angle formed by the APL and the EPB at the entry increases when the radius is raised, it should decrease or disappear if the radius is pulled down, in which case pain should decrease or disappear. The objective of this study is to investigate whether manual traction applied to the radius in parallel with the Finkelstein test relieves pain in Quervains Tenosynivitis. This study conducted was a prospective monocentric study on a group of 36 patients, 34 women and 2 men who each presented with Quervains. Of the 34 women, the age range was 20 to 72 with a median age of 52, and the 2 men were aged 33 and 46. Of the 34 women, 18 were affected on their dominant side, and of the 2 men, one was on the dominant and one was on the non-dominant side. Of 10 out of the 36 patients, which equaled 27.8%, their triggering factor for Quervains was related to the care of newborns, such as 6 were mothers, 1 was a father, 2 grandmothers, and 1 child care worker. A few other examples of triggering factors were 2 patients had trapezometricarpal joint prosthesis, 2 were musicians, 1 was a student with regular writing and computer use, 1 overpulled weeds, 1 was overuse with walking stick. The inclusion criteria included the individuals to be of legal age and in good general health, with no history of chronic rheumatic disease or neurological pathology. Pain had to be precisely and uniquely on the edge of the wrist at the level of the lower end of the radius where the extensor retinaculum is located. Exclusion criteria included the minority regarding patient age and imprecise location of pain. If the pain overflowed onto the back of the hand or rising up to the forearm, they were excluded. The patients experienced pain for about 2.5 months. The researcher provided a questionnaire assessment to the patients on their first session, with only 2 items taken into account. Does performing a Finkel test trigger pain? Yes or no? And then number 2, can you rate the intensity of pain caused by the Finkelstein test from 1 to 10? 1 minimum of pain, 10 maximum pain. The second stage of the article was redoing the Finkelstein test, but this time combining it with the manual traction on the radius performed by the examiner. The patients were then asked the same 2 questions. Does performing a Finkelstein test trigger pain? And can you evaluate the intensity of your pain caused by the Finkelstein from 1 to 10? For the first test pain intensity value, it showed that the mean pain intensity value was equal to 5.83 out of 10, with a minimum of 3 out of 10 and a max of 8 out of 10. We showed that both men rated pain 7 out of 10, and then 3 women 3 out of 10, 4 out of 10, 5 out of 10, 2 5.5 out of 10, 10 6 out of 10, 4 7 out of 10, and 6 8 out of 10. And then when the traction was done, the mean pain intensity value was equal to 1.86 out of 10, with a minimum of 0 out of 10 and a max 4 out of 10. Both men rated 4 out of 10 pain with the traction compared to without the traction 7 out of 10. 8 women reported no pain. 8 women reported 1 out of 10. 8 women reported 2 out of 10. 6 reported 3 out of 10, and 4 women reported 4 out of 10. The results of the pain intensity value of the Finkelstein without and then with the manual traction show that radius traction led to a decrease or even disappearance of pain in all patients. 8 patients saw their pain disappear completely. Pain decreased by an average of 3.97 points, with a minimum decrease of 2 points and a maximum of 7. So it showed that traction on the radius is beneficial for all patients who present with Quervains Tenosynivitis and makes it possible to reduce symptoms. But there's much to continue to discuss with this article. First, this article study is far too small to lead to certainties and a larger scale and multi-center study is needed. It also has additional questions from the study, such as what causes the ascent of the radius. There was another study carried out in 2013 of a 3-dimensional measurement of ulnar variance during forearm rotation that showed that pronators teres and pronation movements of the forearm led to an automatic ascent of the radius in relation to the ulna. More research regarding the ascent of the radius, penetration angle, and the involvement in the pronators teres causing upward rotation of the radius is needed to develop a rehab protocol and treatment. As per the author, a study is underway. I just thought this was very interesting article. I have even tested this in my clinic with a few of my patients with Quervains Tenosynivitis, and the manual traction did report with decreased pain during the Finkelstein, which then can increase the ability for patients to stretch and to be able to move a little bit better for those who are very stiff and difficulty moving because of the pain. I have a lot of patients with Quervains sometimes, and I always feel like what else can be done other than bracing and cortisone injections. I feel like the home exercise program with these patients isn't always successful because I don't feel like they're following it as closely as they should. So I just thought this was interesting, that brings up a different perspective as well as more additional questions of the radius and how it ascends and decreases. And I hope everybody else found this interesting as well. Thank you.